1 in 3. That's how many American men will face physical violence, sexual assault, or stalking by an intimate partner. 1 in 3 women worldwide will endure physical or sexual abuse, most often by someone they know. But domestic abuse isn't just bruises. It's manipulation, it's fear, it's control that seeps into every part of your life. I'm Ingrid Dutton, and I survived it. Then I created 1 in 3 so no one else has to suffer in silence. Each week, we break that silence together. Occasionally joined by survivors, loved ones, and experts, we talk about the pain, yes, but also about the healing, resilience, and the fight to reclaim your life. This podcast is more than awareness, it's a lifeline. And a reminder, you are seen, you are heard, you are never alone. Search for 1 in 3 wherever you get your podcasts, because every voice matters and every story deserves to be heard. There are over 500,000 babies admitted to the NICU each year, which is approximately 10 to 15% of all babies born in the United States. NICU, which is an acronym that stands for Neonatal Intensive Care Unit Month, is designed to honor families experiencing a stay in the NICU as well as the health professionals taking care of them. Hey everybody, welcome to another situation. It's me again, Ingrid, one of your hosts. Don't worry, Jessica is at the end of this episode one more time to join me. So I talked a little bit about NICU, and some of the reasons that babies are admitted to NICU include preterm birth, birth defects, breathing and feeding problems, infection, or some other medical conditions. And I was privileged to speak with one of the health professionals that formerly worked in NICU, Michelle Harris. She's an RN who's recently retired. And she goes into her profession as a nurse, starting off with pediatrics and then transitioning into the NICU. Also, at the end of the episode, she and I talk a little bit about her podcast, the Conversing Nurse Podcast. So make sure you stay tuned all the way to the end to hear those details. Here's Michelle.
Okay, well, my name is Michelle Harris. And first of all, I want to thank the girls, Ingrid and Jessica, for having me on today. Thank you, ladies.
We're excited to have you. Thank you for coming on.
Yes, it's my pleasure. So I am a registered nurse, newly retired, and I worked my entire 36-year career in pediatrics and the neonatal intensive care unit. And so I entered into the healthcare arena at age 17. And I was a certified nurse's aide, so not a nurse, basically taking vital signs, helping patients up to the bathroom, walking them, turning them, talking to them, all those kinds of things. And when I got hired, there's a big things were much different then. So in 1981, when I got hired, my nurse manager who interviewed me, her office was right around the corner from the surgical unit of which I was applying to. And so I walked in her office and she was smoking. And that was something that was very commonplace back then. Employees could smoke in the hospital. The patients could smoke if they got permission from their physician. So just, something that would never happen today. Most campuses are smoke-free. It's really hard to find a place if you want to have a cigarette. So she interviewed me and said, yes, I want you. Let's walk down the street to the Human Resources building. And on the way down, she said, you're 18, right? And I said, no, I'm 17. And she said, no, I think you're 18. And I was very naive. And I said, no, I'm 17. And then she really looked at me and made eye contact. And she said, you're 18. So I said, oh, I guess I am. I'm 18. So, that's one of the things that I tell, my friends that's haunted me my whole career, 40 years, thinking that one day, the CEO is going to walk in and say, you were hired, illegally and leave right now. Of course, that never happened, but it was always in the back of my mind a little bit. So I worked as a nurse's aide as I was going through nursing school. And one of the things that really helped me in my nursing, preparing for my nursing career, was that the nurses on the surgical unit and the surgeons kind of took me under their wing and they said, here's what you need to do if you want to learn really fast. Read everything you can in the chart. So read the history and physical, which is a document that talks about the patient's medical history and then the findings on the assessment that the physician makes. Read the surgical report. So the surgical report is, a report of what was done during surgery. Read the nurse's notes. At that time in the early 80s, we had no electronic medical record. It was all paper charting. So on my downtime, I just did what they said, and I learned so much so fast about anatomy and physiology, all the medical terminology, and it really helped me kind of just go through nursing school without too many problems. And so now I am a new nurse, and I'm 21 years old. And that's a baby to me. I definitely feel like I was very young. And the situation at the time when I graduated in 1985, there was a nursing glut. So, of course, now we know there's a severe nursing shortage. But back in the mid 80s, there were a lot of nurses and not very many jobs. There were 4 jobs at my institution. One was orthopedics, one was oncology, which is cancer, one was renal, and one was pediatrics. And so this was my reasoning. Pediatrics, kids. I like kids. I'm one of 8 kids. I helped raise my younger siblings. Kids. How hard could it be? Yeah, well, it was really hard, especially the first time that I had to put a 3-year-old in a body bag. It was really hard. And I was 21 with 0 experience. So, I was thinking about some of the mistakes or the regrets that I've had along the way, and 2 really jumped out at me. And the first one was we had a child in our unit who had a ruptured appendix. And so when it ruptures, all that infection goes into the abdomen and you get what's called a peritonitis. It's an inflammation of all the lining of the abdomen, all of that stuff. And kids get very sick from this. And so after surgery, it was a long recovery. He had to have antibiotics for about 10 days. And this child was probably around 9 or 10 years old. So he'd been with us for a while and he was getting better. And now it was discharge day. And I was his discharge nurse. And we went through the whole discharge process of instructions and so forth. And his mom had been with him the whole time. And so now he's in the wheelchair and we're getting ready to wheel him out to his car. And he is incontinent of stool in his pajamas. And so his mom says, he pooped his pants. And I said, "Oh my goodness, let's get him out of the chair and let's change him. Let's clean him up." And she said, "No, let's just go." And I said, "But, she says, "I don't have any more pajama bottoms." I said, "We have pajama bottoms. You can take them home. It's not a big deal. It'll just take a few minutes." "No, I want to go. We only live 10 minutes away. I just want to get out of here." So I said, "Okay," and took him down, put him in the car, and let him go. And a couple days later, I was called into my manager's office, and she reported that this child's mother had called and was not happy with the nursing care that I had delivered. And why did I do that? And so I'm sitting in her office as a 21-year-old nurse, and I'm trying to explain that I offered to, help clean him up, change him. I offered some of our, hospital pajamas, and that she was adamant she didn't want to. She wanted to go home. And of course, my manager told me all the things that managers do. You should have talked to one of your colleagues. You should have called me. You should have insisted. And so, that left me with kind of I didn't get written up or anything, but I just felt so bad. I felt so bad in the moment when it was happening. And then, of course, when I was being, counseled, I just felt bad all over again. Like, yeah, this is something that I could have done differently. And so things like that, they stick with you your whole career, but it's helped me be a better nurse because now I know I have all these other resources. I could do this. I could ask one of my colleagues. I could have called my manager. So it was definitely a teaching situation, a learning moment for me. The other thing that jumped out at me during my pediatric nursing days was in the mid 1980s. This was also when I was very young, 21 or 22. We had a large influx of Southeast Asians because of the war over there, and they were coming to the Central Valley. And so all of a sudden we had a lot of patients that were Hmong, and lovely, lovely people. But we didn't know anything about their culture. They were brand new to us. We had no interpreters. We had no, frame of reference. And so I remember a little girl coming in one day for gastroenteritis, which is vomiting and dehydration, diarrhea. She was dehydrated. So we needed to start an IV on this girl. And we took her into the treatment room, and we typically start IVs on children on their hands. That's a typical place that we would start an IV. And this young girl had some strings wrapped around her wrists, and we didn't know what they were because we didn't know anything about their culture. And so in order to have full access to her hand and her wrist, I cut those strings off and I put them in a little Ziploc bag to give to the mother. We started the IV and we took the child out to her mother and, handed her over and then gave her the bag of the strings. And if you've ever heard a mother wail at maybe her child being, wounded or, her child die, that's the sound that came from this mother. And she was like throwing herself on the floor and she was crying and yelling. And so we had to call someone in the community to come and translate for this lady. And what this translator told us was that we had cut off the strings. The strings in their culture are meant to protect the child and to keep the child's soul intact. And so we had cut these strings and basically released this child's soul. And talk about having cultural competence. We did not have it. We didn't know anything about their culture. There's a great book that was recommended to me, and it's called The Spirit Catches You and You Fall Down by Anne Fadiman. And it's about a Hmong family, and the child has epilepsy, a seizure disorder. And it's just kind of about healthcare and how we missed the mark a lot with this child. And it was actually a family that lived in the Central Valley here. So, because of this, we needed to learn about different cultures really quickly. And again, another teaching moment, when we have people from different cultures come in, we immediately, get in our books, get on Google to try to, figure out, ask their translator, and to figure out what they need and how they need it and what their expectations are. So those are some two really big things that stuck out in peds that you could call regrets or mistakes. The rest of pediatrics, I absolutely loved it. I love working with children. They are so trusting, and you have to earn their trust. If something hurts, you tell them this, I have to start an IV on you. It's a little tube and it goes in your hand and it gives you some water and some medicine so you can get better. And it's really interesting to see their wheels turning in their head. Well, how do you get the tube in my hand? Well, we use a very small needle. And that's usually the point, depending on the child's age, where, they start crying and getting anxious. And, they say, does it hurt? And you say, yeah, it does hurt a little bit. It feels like you're being pinched. Have you ever got stung by a bee? It feels like you're getting stung by a bee. But your mom and dad are going to be right here, and you can tell me, we'll say 1, 2, 3, and you can tell me when you want me to poke, but I need you to hold your hand really still. And just that whole interaction with the child and earning their trust and them then trusting you, it's just a wonderful experience. And so if you're a parent out there and your child ever has to be hospitalized, honesty is the best policy. Just tell them the absolute truth. One of the things that we saw a lot in pediatrics was, maybe this child had surgery and he was recovering and was acting out like kids do because they're in a different environment and so forth. And the parent saying, you better stop that or the nurse is going to come in and give you a shot. And it's heartbreaking, and then we have to backtrack and say, no, I'm not giving you any shots. And that's usually right after you earned their trust. And now
that kind of takes the trust away, right? Now they start to be afraid of you.
Absolutely. So you got to start all over again and provide a lot of education for the parents about the behavior. This is normal behavior. He's out of his element. He has pain. He's under the effects of medication. Like, let's let some of this stuff slide a little bit. And then we would get the child up and go to the playroom and, use all those great distraction techniques that we've learned as nurses and parents, because parents do those things too, right?
Well, I think it's the parents that turned me away from pediatrics. I remember I love kids. I had 3 of them. And I remember going in and I think I was a discharged student nurse one day, and all I had to do was take an IV out. That's all I had to do. And the mom was in the room with her daughter, and I was starting to take it out, and the daughter was screaming and crying because she remembered it going in and thought it was going to be the same, plus tape pulls.
Oh.
And the mom just started screaming at me, "What are you doing? Do you know what you're doing?" I'm like, "I'm just taking an IV out." And I was like, I can't do this.
Yeah. I mean, that's the other thing. And we'll talk about NICU in a minute, but kids don't come alone. They come with their family. They come with their parents. And so you might think that you're just treating the child, but it's not that easy. It's a package deal. And I learned that even more when I got into the NICU, the neonatal intensive care unit. So I spent 18 years in pediatrics, and then I left pediatrics to go to the NICU. And sometimes, when people say, "Oh, why did you go to the NICU?" they're expecting to hear like a very lofty reason, and it wasn't a lofty reason. At the time, we had a manager in peds that was also the manager over the NICU. And we were trying to get a really important designation from the state of California called a California Children's Services Designation, or CCS. And CCS provides extra funding from the state for children that have maybe been injured or sick or born prematurely or born sick or born with defects. And it kind of is like a supplemental insurance. It pays maybe the rest that their insurance doesn't pay. So there's a lot of things that we have to do to get prepared for that. And at that time, they said the manager, each unit has to have their own manager. So my manager in peds actually had a lot of NICU experience, and she said, "I'm going to go to NICU." And I had a great rapport with this manager. She was a mentor. She was a friend. And I said, "I'm going to go to NICU too." And NICU wasn't foreign to me. Being in pediatrics is generally not a really busy unit. They have their times of busyness, like in the fall and winter with a lot of asthmatics and a lot of flu. But most of the time it's kind of quiet in pediatrics, which is great to not see a lot of sick kids. So I had floated to the NICU quite a bit. And that's usually the life of a pediatric nurse. They float to the NICU. They're kind of sister units. There's a lot of familiar things in both units. So I was not, so I was familiar with the NICU, and I followed my manager there. And that's when I really became invested in it and really started to love it. And the reason I was reflecting back on why did I love the NICU so much, I think it's just such a special population. Again, like I had just said, the babies come with their parents. So it's a family, and I loved seeing the transformation of the families. So for our listeners that might not know which babies come to the NICU, the NICU is an intensive care unit for neonates, and most of our population are premature babies and babies that are also born maybe sick with an infection, or they had some trouble at birth, maybe some trouble transitioning to breathing air instead of not breathing air. And so they just need a little bit of help. So that's typically who's in the NICU. And of course, they come with their mother and their family. And when they come to the NICU, it's usually always like a plan B. It's nobody ever raises their hand and says, when my baby's born, I want my baby to go to the NICU. It just doesn't happen. And so there are very few babies that come to us where they know they're going to come. Maybe we know a mom is being induced prematurely because something's going on and they need to get the baby out. So then, her doctor will inform her that, we're going to deliver early. So she has a little bit of notice. But most, it's just something's going on with your baby. We need to go to the NICU. And it's very traumatizing. So when they come in, they are scared. They're out of their element. They missed out on things like doing skin to skin, or maybe putting the baby to the breast for the first time because the baby was not doing well or not ready. And so they're struggling. And, we get them settled in and we start giving tons of information, support from the very beginning. We start planning for this baby to go home. Even if this baby is 25 weeks and weighs 500 grams, which is about a pound, and we know the baby's going to be with us for about 3 or 4 months, we start planning for discharge and talking about discharge right away. So I loved seeing the transformation of maybe that baby's there a week. And when the baby came in, the parents had no idea how to hold or touch their baby. They had no idea what the baby's cues were, how the baby spoke to them, how to interpret those signs. And then within a few days, they are learning that baby, they're bonding, they're doing skin to skin, and they go home with a feeling of confidence, like, wow, I can do this. I can be a parent and take my baby home, and everything's going to be all right. So that's an amazing gift that we as NICU professionals get to see and be a part of. I think the other reason I love NICU is we do, before COVID, everything is before COVID, right? We used to have the March of Dimes was great about having reunions. So once or twice a year, we would have reunions for our graduates out of the NICU. And just to see those kids come back and to see them doing so well and to connect with their parents again. And, the parents tell us stories about, when you were my baby's nurse, and do you remember you did this or that? And it's great when we remember. Sometimes we don't remember because we see so many babies, but it's great when we do remember. And it's just great that they remember that we did that and that it touched them in some way. And we get pictures every holiday. We get family pictures, Christmas pictures, birthday pictures. And so it's encouraging to us because if we didn't get that, we wouldn't know what the outcome was. We wouldn't know how well they're doing. And you miss out on that. You know that while they were under your care, that you were doing something good. And you always hope for the best, to have the best outcome, but you don't really know because there's not any follow-up. So to have those connections again is really important. And I think it keeps nurses and physicians and our occupational therapists and our physical therapists and our respiratory therapists and just everyone that's involved in the care of an infant. It just keeps us going. So I think that's why I love NICU so much.
When you would have the reunions, would it be the whole medical team would be there for it?
Yes, it was anybody that wanted to volunteer. So there's a lot of people in the NICU that that touch a baby. There are case managers. Like I said before, there's respiratory therapists that are there with us every day. There's unit clerks. There's volunteers. Just a whole lot of people that are behind the scenes. Social workers. We have a maternal child health social worker. That those people are amazing, and the parents don't always see them. A lot of times they're behind the scenes. So to be able to connect at that time is just a really special time. And one of my other jobs in the NICU was a lactation counselor. And I did this because you're working with babies and moms, and most of those moms, their goal was to breastfeed. And something got in the way of that. The baby got sick at birth and had to go to the NICU, or the baby was born too premature and couldn't breastfeed at that time. So I just saw a need there. And I always, my friends laugh at me, but I say the best thing to be is to be a NICU nurse and a lactation specialist, because you are working with moms and babies every day, and you have that extra knowledge of what they need. And the moms need a lot of support. They need a lot of support. I'm underlining that right now. They need a lot of support. They're in an element. They didn't get what they wanted. They wanted to have a nice birth, a term baby, a baby that wasn't sick, a baby that wasn't premature. NICU moms have a mountain of guilt on their shoulders at all times. You can see it on their face. You can hear it in their voice. They are burdened with a ton of guilt. And that's something that, you can't take that away. When we see that, we see it, we know it, we acknowledge it. But it doesn't work to just say, well, don't feel guilty about this. It's the same thing as when somebody's really angry and you tell them, calm down. It doesn't work. You have to provide a lot of information. So we have to provide all that information of why the baby was born premature. It didn't have anything to do with them. And then just give them the tools that they can use to empower themselves. So lots and lots of education. What I found being a lactation counselor is women do not know how their bodies work. A lot of women do not know how their bodies work. And I would see that every day. For instance, if they started pumping because they're trying to get milk for their baby, and we give them, a 2-ounce bottle, and they think on their first pumping that the bottle is going to be full of milk. And they are so sad when they get 1 or 2 milliliters, a teaspoon. And we're so excited when they bring it. And they have this look on their face like, I don't even want to give this to you. I'm so embarrassed. And we see it. And they have a little 25-weeker that weighs 1 pound, and they got 10 milliliters, which is 2 teaspoons. And we're like, oh my God, this is amazing. And they're like, what? Are you serious? So, things like that. It's really fun to provide the education about the norms, and then see when they bring the next pumping and they're up to 15 mils, they're proud. They're bringing that in and they're proud. Their baby might be starting on feedings of 1 milliliter every 6 hours. So think how far that 15 milliliters is going to go. And it's great to see that. So I love seeing their confidence go up. I love seeing them figure out what their baby is capable of. Because if you're looking at your child who weighs less than 1 pound and has a million tubes coming out of them and is on a ventilator and is in an isolate, and you just see that baby as being so fragile. A lot of parents at that point, they don't even want to hold the baby because they're afraid that the baby is going to pass away. They're afraid they're going to hurt the child, that they're going to pull out one of the tubes. So as soon as that baby is stable, we get that baby skin to skin right away. That is the magic. That's where everything happens. That's where bonding takes place. That's where the parent's confidence level goes up, and they can see the strengths of their child. They can see the child's competence instead of just this very fragile child. And nurses are so great, and physicians are so great at pointing those things out. A 25-weeker can suck on its hand. And we point that out. Look, he's sucking on his hand. He must be hungry. So it's really amazing for the parents to see their baby progress over the weeks and the months, learn their baby's signals, because obviously babies can't talk to us verbally, but they give us lots and lots of signals. And we teach them what those signals mean and what to do when they see those signals. So it's really very satisfying. So that's why I like being a lactation counselor. That's why I've loved being a NICU nurse. And, this is something that I ask nurses when I talk to them. What's going right in nursing and what needs to be fixed? And I've heard a lot of different things. Of course, right now we're in a very severe nursing shortage. We have a lot of burnout. We have, this post-COVID, everybody's sick of it, but we still are doing all the things that we need to do. So there's a lot of, we're just done with it. And so I think, one of the things that I would say, if you're a nurse and you're still in it and you still want to do it, but maybe you're not feeling it, some of the things that can help you is to get involved in a professional organization. And I was involved with the National Association of Neonatal Nurses, which is NANN, N-A-N-N, for decades. And when you're a member of a professional organization like that, you get access to journals, to lots of literature, lots of research, to conferences. Yes, it costs a fee every year. Many hospitals will reimburse you for that fee. Recently, I became a member of ILCA, which is the International Lactation Consultant Association. And I want to make the distinction that I am not a lactation consultant. I'm a lactation counselor, and they're very different in their scope of practice and what we can do. So, but that was available to me, and it's helped a great deal. And get certified in your specialty. That's another thing that really will help you build your confidence skills. You just can't go wrong with getting certified. That certification says that you are the best in your specialty. Patients like to see that. Organizations like to see that. And even if they didn't like to see that, it's important that you see that and that you know that and that you have that extra certification. Make friends with your hospital medical librarian. They are amazing people, and they're underutilized. When I became a developmental specialist in the NICU about 12 years ago, I didn't know anything about it. I went to a conference and I got fired up, and my manager said, you need to do this. And I said, I don't know what to do. So she got me some books on it, and I became a member of NAN, and I called the librarian and I said, I need anything you have on NICU developmental care, on feeding protocols, on whatever it was. And that person is vital to your research as a nurse. Nurses can be leaders even though they're not in a leadership position, so like in a management position, but anybody can be a leader. And nurses, I think, especially need to be leaders. Be the person on the unit that other nurses go to. Be a mentor. Do your research. Take initiative. Being a leader doesn't mean working all the overtime or picking up all the extra shifts, because that will, lead to its own difficulties.
Those long hours are enough as it is, and then extra shifts on top of it.
Oh my gosh, yeah. And then I put self-care, self-care, self-care. And we hear that a lot. And I think nurses get kind of burned out on that. It's like they say, well, take care of yourself, but then, hey, we need somebody for night shift. So nurses have a hard time saying no. In general, I'll say that. And I have to say self-care because I made the mistake of not practicing self-care. And in 2009, I was working a lot of extra shifts. I was not taking care of myself in terms of doing any kind of exercise. I was eating out a ton. I was stressed out a ton. But the money was really seductive. And we had 2 daughters in college, and we put them through college cash. We didn't get any loans. But I did this for a couple of years, and then I got diagnosed with breast cancer. So it's really funny how the universe says, hey, remember last year I told you to slow down? Remember last year I told you to take care of yourself? Remember last month I told you to, you need to get out and move more, or be an advocate for yourself, or whatever it is. And then all of a sudden the cancer says, hey, I tried to talk to you, but you wouldn't listen. So that whole thing was about 6 months of chemo and surgery. And there are a couple times where nursing saved me. And that was definitely one time, because my boss and my oncologist, they let me work part-time during that chemo. And I was really careful. It was also the height of H1N1. You guys might remember that, 2009. Yeah. And we had a ton. Yeah, right. So I didn't get H1N1, and I'm going to knock on wood. I didn't get COVID yet. So we're 2.5 years out.
You and I are the only 2, maybe.
Woo, yeah, I know, right? So when you meet another person and you find out they're a COVID virgin, it's like, oh, wow, awesome. Yeah. So the other time that nursing saved me was when my husband unexpectedly passed away in 2016. And I had a very understanding manager. I wanted to go back to work in 2 weeks. And she said, really? Are you sure you can do everything you need to do and be okay in 2 weeks? And I said, oh, maybe not. Maybe I need to take more time. So I took 8 weeks, and just had great friends and just a great support system. So I've been thankful for having such a great career and being in such a great profession. It's been a real joy for me. And then I retired in 2022, January. So it's only been about 9 months. And I knew that about a year before I retired, I knew I wanted to start a podcast, because I knew it was going to be difficult for me to leave the nursing profession. So I said, I need to be connected to nurses, and I'm going to start a podcast, and I'm going to talk to nurses, because in my whole 36-year career, I've been a NICU nurse and a peds nurse. I don't know what it's like to be a dialysis nurse or, a nurse anesthetist or a nurse researcher. So a lot of it is my own curiosity. And I think there's probably a lot of other nurses out there that would like to know what nurses in other specialties do. So I've enjoyed my retirement so far doing that and doing a lot of self-care, a lot of walking and reading and cooking and playing with the grandchildren and just taking care of myself in all those different situations.
Well, since we're on that topic, what's your favorite self-care practice?
My favorite self-care is, I guess it would be routine. So getting up at the same time every day, going on a walk. I eat the same thing for breakfast every day. It sounds boring, but it's so comforting. I just love it. And my coffee, and I watch 30 minutes of the news and then I turn it off, and then I go in my craft room and I make cards, or I read, or I research for my podcast. And so I think that's self-care, just kind of knowing the things that bring you joy and allowing yourself to do them.
That sounds perfect. So let's talk more about your podcast.
Yes. Okay. So my podcast is called the Conversing Nurse Podcast. And today I just released my 8th episode. So from what I've heard in the podcasting world, since this is all new to me, is that it's a huge number, like over 40% of podcasts never get past episode 8.
Yeah, I've heard the same.
Yeah, have you heard that too? Okay. And, the reasons for that are because I think people don't realize what's involved. They don't realize how difficult it is. And so releasing 8 today has been like, whoo, okay, I have 8. I have a few in the can. I'm going to make it past that statistic. And so that's been really fun. And just, I'm in the flow mode right now of, I know how to record. I know how to edit. I know how to publish. I know how to do the social media blitz. And so I've just been in a state of flow, and it feels good. And I get excited for every interview because I feel like I'm learning along with my audience. Like I said before, I don't know what it's like to be, a flight nurse. I don't know what it's like to be a nurse entrepreneur. And so having these conversations with these individuals has been really a great learning experience for me. And I always hope that my audience is enjoying that too.
Absolutely. I've listened to, I don't think I heard your most recent one, but I've listened to all of the rest of them. And
thank you.
It's funny, in nursing school, I thought I wanted to do pediatrics or OB. And then when I got into those rotations, I realized I didn't want to because I didn't like the parents.
And 100% true.
Mm-hmm. And then I thought I'll never do cardiology, but somehow I had a cardiology rotation and I kind of fell in love with it and ended up out of nursing school going to it was kind of a multi-system, but tried to focus on cardiology and cardiac care patients, but like post-angioplasty. Then I stayed with that. And then I went back to get my master's, and I didn't want to pigeonhole myself into cardiology. So I thought, let me try something else. So I went and I did kidney transplant, which was hugely different than what I was doing.
That's huge. Yeah.
Yes. And I absolutely loved the team that I worked with. There were 3 surgeons, quite a few nurses, and like pharmacists, social worker. It was so much fun, but I just didn't have that passion for kidneys. And I really tried, but there was a cardiology group that was hiring. So I went back to cardiology, and then we opened a heart transplant program in Orlando.
Wow.
And so I went back to transplant. And now I'm not doing that. I'm still doing cardiology up in Tennessee now, but yeah, it's so fun to listen to your podcast, to hear all of the different varieties of nursing professionals and what drives them. And what's great is you've picked really like amazing guests to be on, because that you can tell their excitement behind what they're doing. And I think that's so key, is to hear that excitement, to know you're in the right realm of nursing if you have that spark, that, just excitement. And hearing you talk tonight of, all the various extra disciplines that you learned, lactation and everything, it definitely, that was so your calling. And I know you were saying there's a difference between counselor and consultant, but my goodness, I had the hardest time with my lactation consultants when I had my oldest, and it actually made it very uncomfortable for me, and I felt like I didn't know what I was doing, and I was super just kind of disheartened and couldn't. I felt like I kept failing every time. And then they would check on me and I'd say, oh yeah, he fed for like 30 minutes. They're like, no,
great.
He did not. But they wouldn't. They're like, he did not. He fell asleep and he was just, and I was like, well, okay, but he's there.
Yeah. I like to describe lactation counselors more as like, we're cheerleaders. We provide a lot of basic information about the body, how the body works, how babies work, all those things. And, but we are there to empower the moms, to help them find their voice, what they need. And that's one of the things that's so satisfying is we've had moms that their babies have been in the NICU for 3 or 4 months. And I am literally seeing those moms every single day. And, I see what goes on. I love being able to communicate in a way that helps them say what they need to say. Like, one of the things we learn in communication is to ask open-ended questions, right? And so an open-ended question is when I have a mom in front of me and she's crying and she's saying, my milk supply has gone down and I don't know why I'm pumping this much and I'm doing this. And I can see she's just totally, frustrated. And so I say, tell me what's going on at home. What's your life like at home? And then she says, well, my husband's back to work and my kids just started school and I'm coming here in the morning and I'm being with the baby and then I'm leaving and I'm going home and my husband's coming home for lunch and I'm fixing his lunch. And then I rush back to the hospital to be with the baby. And then I rush over to pick up my kids after school and take them to soccer. And then I rush home and I make dinner and I rush back here at night. And I'm not sleeping. And, you get a lot more information than if I had just asked her, how are you today? Because if I don't want to talk about it, I'm going to say, fine, I'm fine. Like when you have a fight with your person and they're like, what's wrong? And you're like, nothing.
Exactly.
It's the kind, and I would get that from the moms if I asked the wrong way. And so, them just being straight with me about what's going on. And, I just make an observation. It sounds like you're really burning the candle at both ends. And what could you give up? What could you delegate? that you could stay here maybe 30 minutes longer and do skin to skin or pump at the bedside. And so then we look into all those different things that they can do. But yeah, it's great. It's a great profession. I love that I'm still able to talk to a lot of nurses because, we know each other. We know how we are. We know our idiosyncrasies. We know what, makes us cringe, and we know what makes us laugh, and all those things. I just think nurses are very special individuals.
I agree. And what a good idea to do after retirement to keep it up.
Yeah, I can't leave nursing 100%. I still have some of it in me. We have 6 nurses in our family, so a big family of nurses. Yeah. So we still talk nursing shop with each other and all that. And I'm still involved. I just went to an ethics meeting today, so I'm now a community member of the ethics team. I was a legit member, I guess, when I was working for the institution. And then I volunteered for our hospital advisory board and stuff like that. Because retirement, even though, it's got a lot of press about being really great, for me, it had its difficulties the first few months. I really lost the routine, which when you work in a hospital, every minute of your time is accounted for. So being ultra scheduled, going to retirement and having zero schedule, that was very difficult to get used to. And then the social aspect, I had a desk and the nurses would all come by and we'd chat and I'd go give them a break. And, so that whole, we'd have, potlucks. And so there's a loss of that too. Nurses love their potlucks, right?
Absolutely.
I just like to eat in general.
I know. Donuts in the morning, potlucks.
Oh my God. Yeah.
So much fun.
Yeah. So I am very thankful that I'm still connected, and I'm still a nurse. I still have an active license. So every so often I go, maybe I want to go back to work. And then I let that feeling pass. Mm-hmm. And then I go, no, you need to concentrate on this right now. So, but this has been
it's great to keep up everything you're doing because, you always hear, how do you stay healthy after retirement? And you have to physically healthy, mentally healthy. And so many people, once they retire, all of a sudden they start developing all these sicknesses and everything. And even depression is huge too, because that routine's gone. So to find something to keep your passion going is a brilliant idea and such a good idea to do a podcast. Very fun.
It's fun. And we need to have fun in our lives, especially right now, but I think all the time. So this has been an absolute joy for me to be a guest. I have to say I was slightly nervous because, now I know exactly what my guests are feeling. And so this has been a really good experience for me to know exactly what my guests are going through. Because when you're on the other end, it's just easy, right? You're asking the questions. And so thank you for this opportunity.
Well, thank you so much for coming on. It was really fun to have you on and to hear your pediatric and NICU stories and hear your passion. Again, you can hear it in how you detail everything. And I do love your podcast. I am a fan. And
I am of yours too. You have quite a few more episodes than I do. So I think I've listened to 5 of them so far. And today on my walk, I listened to the Tuskegee. And let me tell you, I love that one. You guys did your research. That was so well done. Yesterday, I listened to the pediatric cancer episode.
Oh, yes.
Oh my gosh. I mean, just really amazing work. I love it.
Thank you. Thank you.
So
well, it's easier for us because there's 2 of us, so we get to, and me being the older sister, I sort of just dictate to Jessica what happens.
You're the bossing around.
Yes, I am.
Oh, I know. I missed Jessica today. So hi, Jessica.
Oh, she's so disappointed. yeah, she has quite a bit on her plate. So she'll be back around. I think she's going to take next week off as well, but she'll be back.
Self-care, right?
Yes. Yes. And she's a social worker. And so she knows all about mental self-care.
Right.
And she's all about it. She's better at it than me.
That's when she tells you, Ingrid, you need to be doing this or that or the other. Yeah.
Exactly.
You guys complement each other very well.
Oh, thank you. I think you and your sister should. I liked that episode that you did with her.
Oh, thank you. That was so fun. Yeah. Yep.
But okay, so one more time, let's give your podcast a plug so everyone can check it out.
Oh, yeah. Thank you. So the Conversing Nurse podcast. And my website is theconversingnursepodcast.com. You can listen from there. You can listen on all the platforms, Apple Podcasts, Google, Spotify, all wherever you like to listen. But it's been a joy and it's been fun and I made it past 8, so I'm really excited.
Yes, congratulations.
Thank you.
Okay, well, I guess it's still pretty early there, evening.
Yeah, it's dinner time here. It's probably bedtime for you.
Getting there, yeah. It is. Well, thank you again so much, Michelle. It really was a joy to have you on.
And the pleasure was mine, Ingrid. Thank you so much.
Okay, take care. We'll keep in touch.
You too. Okay.
Michelle, thank you again for coming on to our podcast. And ladies and gentlemen, I have a very special treat for you. I have somebody else with me. Jessica is here.
Michelle, I'm so sad I missed your interview, but I listened to it and it was amazing. There was a lot of good information there.
It was a lot of good information. And
I did want to say something. Since you brought up the Tuskegee Airmen, so I found out over this past weekend, I had to work on Saturday. Oh, what?
Well, she brought up the Tuskegee episode.
That's what I meant. What did I say?
Airmen.
Oh, geez. Okay. Well, it has to do with Tuskegee Airmen, actually. That's why I'm bringing it up. So there's a new Texas State Veterans Home opening up in Fort Worth, and it's going to be named after the Tuskegee Airmen. And 3 of the 5 surviving Tuskegee Airmen are going to be there for the opening. Yeah, I'm so stoked. Wow. I want to go to it so bad, just to show my support. It's in October sometime. I can't remember the date off the top of my head, but hopefully I get to be there for them and just, man, I can't shake their hand. I don't know, stand there in awe with my mouth open. I'm not sure, but
that's really cool.
Yeah, isn't it? I was super excited when I heard that. Super excited to share that news, and thanks for the segue on that.
No, the unintentional segue.
It was. When I heard it, I was like, "Oh, I should say this." But I thought it was great. And one of the things that I thought about was, especially being a NICU nurse, you want someone to have that kind of passion, and like you want a nurse that has their heart in it,
Absolutely.
Because that's such a tough floor to work on. I can't even imagine. I don't think I could do it, but.
Well, I didn't think about it until Michelle and I finished our recording, but my oldest son was technically considered a NICU baby. Because I was induced at, I think it was like 39 weeks, mainly because I think my OB was just not that experienced, and I clearly was not. And I was ready, let's get induced and get this baby out. It was because I had a high blood pressure reading while I was at my very stressful job. And that was like the only elevated blood pressure. Mm-hmm. And she told me I had to stop working and I had to be on bed rest, even though I was not having any contractions. And she did a full workup and I was not preeclamptic. So there really, truly was no reason, but it was Florida and it was September and I was very pregnant and very ready to not be. So when she said, let's get induced, or let's induce you, I did it. I went in on a Thursday evening and I was put on a Pitocin drip. I had to have a whole number of things done, including manual breaking of my water. And when I finally began contractions on Saturday. Meanwhile, my son's heart rate began to decelerate. And then he had a meconium stain, which, if you don't know, is baby poop. And so they said, okay, we need to take her in for an emergency C-section, which happened. And he had a slight fever, I believe, after he was born. So they were considering him NICU. I don't remember if the NICU was full or if they just thought he wasn't so sick that he actually had to be put in the NICU, because he stayed in the room with me, but he did have a NICU nurse that would come visit. And I recall the NICU nurse was my favorite nurse because I felt like she was the most caring and most understanding of all the nurses that I had during that stay. So thank you, NICU nurses. And Michelle, I'm sorry I forgot to mention that while we were talking about NICU. Okay, so I think a couple things before we do our B's.
Okay.
So once again, thank you, Michelle, for coming on. Thank you for being a fan. And we, like I mentioned, I am a fan of her podcast, the Conversing Nurse podcast. And so we're going to ask all of you guys to rate and subscribe her podcast, but then also ours. Please don't neglect us. And we've said it a couple times, but I don't know that we've ever explained why that's important. But if you rate podcasts and if you subscribe to podcasts, those numbers all count in the gigantic world of podcasting, and it helps to get your podcast recognized more and more, not traction. What's the word I'm looking for, Jessica? Traffic.
Oh.
Traffic. You get more traffic. It gets seen a little bit more. And the more downloads you have, the more subscribers you have, the more likely you are to potentially get a sponsor. So while podcasting is for us a hobby, and for a lot of people it's a hobby, some people it is a hopeful career, but it does cost money. There are different fees that podcasters have to pay in order to get the high quality work like we give you every week. But to get sponsors, that helps to alleviate some of those additional costs that podcasters accrue. What's the word?
Sure. And crew works.
Okay. So that's our big ask for all of you guys today.
So say her podcast name again.
The Conversing Nurse podcast. And it's on all the major players. We'll add a link to her website on our show notes, as well as our website on our show notes, which I don't think we've ever done that before either.
I don't think we have either. How silly.
It's quite silly, but
okay. Should we get to the B's?
Let's get to the B's. Do you want to start, or do you want me to start?
I will go with what I absolutely loved about her talking about: be passionate.
Ah, yes. Well, I'm going to go with, because I felt like a huge lack of this during my hospital stay, be a cheerleader. I could have probably used, especially as a new mom, a little bit more support.
Oh, the word you used was going to be the one I was going to use. I'm going to use it anyways.
No,
be supportive.
You can't.
Why can't I say be supportive?
Because it's the same as being a cheerleader. And I had to use the word cheerleader because, yay, cheerleaders.
Not necessarily. Like, you can cheer someone
necessarily.
on. But being supportive can look different than just being a cheerleader. You don't actually have to talk to be supportive. You could just be there. Be there. Be there for families. Be there at your job. Just be there. Be.
How about you be there on your podcast?
Oh, that's harsh. I'm sorry, guys. Sorry, I've missed out. I will join back. I promise. Just taking a little hiatus.
Well, I thought of two, but I just All I can think is zing. I just zinged you for not podcasting, so I'm not going to say be a podcaster. I like be honest when she was talking about with the kids, if it's going to hurt, tell them. And I think that's, oh my gosh, I mean, being honest in so many aspects of life is such a good idea, but especially with kids, if you want them to tell the truth and be honest, then you need to do the same.
Yeah, I agree. I don't know. I got told a story about how there was a lady I used to work with. She has 2 twin girls, and the ice cream truck would go around their neighborhood, and she would say that when the ice cream truck was playing music, it meant they were out of ice cream. So
okay,
maybe you don't have to be honest all the time.
Right. Okay. So I totally get that. I'm just thinking of all the things I've told my kids about, like potty training and
the Teenage Mutant Ninja Turtles live in our ducts to protect us at night from monsters.
Oh,
that happens.
The fairies that live in my daughter's closet that come out to help. Okay. Yeah. All right. So be honest when
you need to be. Be honest.
Which is most of the time.
It is. Yes.
Okay. We shall see you next week. You shall hear us next week.
And it'll be delightful.
It shall. Okay. Goodbye, all.
Thank you. Goodbye. If you would like to reach out to us or submit your situation, please contact us at anothersituationpodcast@gmail.com or find us on Instagram at Another Situation Podcast. We're also on Facebook at Another Situation.
Another Situation is produced and edited by Point 5 Pinoy. Music is written and performed by Tim Crow.